Hello, everyone, and thanks for listening today. This is the RX Daily Dose. Today's episode is being recorded on Saturday, October 19th, and I'm your host, Ian Parnagoni. We update this podcast every week for healthcare providers, medical professionals, and anyone who has an interest in drug updates. Don't forget to like, share, and subscribe on all of your favorite podcast platforms and social media, including iTunes, Spotify, YouTube, and Instagram. All links can be found in the show notes below. First update comes with another approval from drug maker Eli Lilly, months after winning approval for Emgality as a treatment of episodic cluster headache. The US FDA approved lasmiditan, that's brand named Reyvow, for the acute treatment of migraines. The approval of Reyvow marks the first for this type of medicine class. Lasmiditan is a centrally penetrating selective serotonin 5-HT1F receptor agonist. Reyvow, which has a unique mechanism of action, was approved for migraine with and without aura. The approval of Reyvow follows a wave of calcitonin gene-related peptide CGRP inhibitors approved for migraine, including Emgality, which was approved for the prevention of migraine in 2018. Migraine headache pain is typically described as an intense pain in one area of the head. In addition to the pain, migraine sufferers can experience nausea, sensitivity to light and sound, as well as an aura. According to the FDA, about 1/3 of people who suffer from migraine experience auras ahead of the onset of pain, which can appear as flashing lights, zigzag lines, or even as a temporary loss of vision. The approval of Reyvow was based on results from 2 phase 3 trials, Spartan and Samurai, which both met primary endpoints of alleviating pain in migraine patients, as well as the most bothersome symptoms, which includes the nausea and sensitivity to light or sound. The alleviation of pain and the symptoms typically occurred within 2 hours of taking the medication. The Reyvow phase 3 development program also included the open-label Gladiator study, involved more than 4,000 patients in the treatment of more than 20,000 migraine attacks. Interim results from Gladiator released earlier this year showed safety and efficacy remained consistent with results from Spartan and Samurai. There were some mild adverse effects from the drug, such as dizziness or fatigue. However, Eli Lilly noted that there is a potential for abuse of Reyvow, as there is in other medications for the central nervous system. Reyvow is currently being evaluated by the U.S. Drug Enforcement Agency as a potential controlled substance. That classification review is expected to be completed within the next 3 months. Once that review is complete, the medication will be available in retail pharmacies. Also this week, Novan Pharmaceuticals won approval from the U.S. FDA for its transdermal schizophrenia patch. The approval of asenapine, going by brand name Secuado, marks the first transdermal patch formulation for the treatment of schizophrenia, the company said. The patch is a once-per-day treatment that provides sustained concentrations of Secuado, an atypical antipsychotic drug used to treat schizophrenia. Secuado was approved by the FDA based on positive phase 3 data. The late-stage trial showed Secuado demonstrated statistically significant improvement from baseline in the change of the total positive and negative syndrome scale, that's PANSS, compared to placebo at 6 weeks. Efficacy and safety were assessed during the 6-week treatment period in 616 adults living with schizophrenia. Additionally, Secuado demonstrated statistically significant improvement in Clinical Global Impression Severity, CGI-S scores. That's the key secondary endpoint of the phase 3 study. There are some side effects with Secuado, including uncontrolled body movements called tardive dyskinesia, particularly in the face and tongue. It can also cause issues with the body's metabolism, including an increase in blood pressure or a decrease in blood pressure. Additionally, the newly approved treatment does come with a boxed warning that points to an increased mortality risk in elderly patients with dementia-related psychosis. Those patients are at an increased risk of death from treatment with antipsychotics. Secuado is not approved for the treatment of patients with dementia-related psychosis. Also this week, the FDA approved rivaroxaban, which goes by brand name Xarelto, for an added indication for the prevention of venous thromboembolism, acronyms VTE, or blood clots in acutely sick patients in the hospital who are at risk for blood clots, but who are not at high risk for bleeding. This is the 8th U.S. indication for Xarelto. 6 of those indications are for the treatment, prevention, and reduction in the risk of VTE recurrence in a range of patient populations. Acute medical illness here is a term used to describe serious but common medical conditions. About 7 million people in the U.S. are hospitalized annually with diagnoses that fall within this broad term. They are at increased risk of blood clots, and that risk extends for up to 3 months after leaving the hospital. In fact, about 80% of these blood clots happen within the 6 weeks after being discharged. Current medical guidelines recommend that acutely ill medical patients who are at risk for VTE be given anticoagulants, usually injectable drugs, while still in the hospital, but routine use of anticoagulants outside the hospital is not recommended. These results are part of an extensive clinical trial program of Xarelto. The Phase 3 clinical program includes the Magellan and Mariner trials. Magellan data was published in 2013, which looked at Xarelto in preventing VTE in hospitalized patients with acute medical illness and restricted mobility. This trial began with the patient's hospital stay and continued through post-hospital discharge. That trial met 2 co-primary efficacy endpoints, with Xarelto showing non-inferiority to enoxaparin. The company then ran a post-hoc analysis of Magellan with 5 more criteria that excluded patients who were at high risk for bleeding. This established a promising benefit-risk profile for VTE prevention with Xarelto. The Phase 3 Mariner trial was similar, and the data was published in 2018, with the focus on prevention of VTE or VTE-related death after hospital discharge. Xarelto did not decrease the composite endpoint of VTE and VTE-related death, but it did significantly decrease symptoms of VTE with a good safety profile. Both of these trials are part of the Explorer clinical research program for Xarelto. Explorer is a collaborative program between Janssen and Bayer. By the time Explorer finished, more than 275,000 patients have participated. Also this week, the FDA expanded the indication for baloxavir marboxil, that's Xofluza tablets, to include people at high risk of developing influenza-related complications. The new indication regards patients with conditions such as asthma, chronic lung disease, diabetes, heart disease, or morbid obesity, and for adults aged 65 years or older. The FDA first approved Xofluza 1 year ago for the treatment of acute uncomplicated influenza in people aged 12 years or older who have been symptomatic for no more than 48 hours. The antiviral is given as a single oral dose, and unlike neuraminidase inhibitors such as Tamiflu, which inhibit the action of neuraminidase, Xofluza prevents replication by inhibiting cap-dependent endonuclease activity of the viral polymerase. The expanded indication for Xofluza was granted on the basis of results from the Phase 3 Capstone 2 study, which included people aged 12 years or older who met Centers for Disease Control and Prevention criteria for being at high risk for flu complications. The study evaluated Xofluza 40 milligrams or 80 milligrams, given as a single dose, in comparison with Tamiflu 75 milligrams given twice daily for 5 days or placebo. Xofluza significantly reduced the time to improvement of flu symptoms compared to placebo, Median time was 73 hours versus 102 hours. Efficacy with respect to duration of symptoms was similar between Xofluza and Tamiflu. Median time here was 73 hours versus 81 hours. In people infected with influenza type B virus, the median time to improvement of flu symptoms was shorter with Xofluza compared to placebo, 75 hours versus 101 hours. Adverse events that were reported in at least 1% of adult and adolescent patients treated with Xofluza included diarrhea, bronchitis, nausea, sinusitis, and headache. And the last update I have is actually an update from the American Thoracic Society, which published an official clinical guideline update to the diagnosis and treatment of adults with community-acquired pneumonia. This update came out October 1st, and you can find the full link to questions and answers about treatment in the show notes below. I'll keep the updates related to antibiotic treatment in the outpatient setting, but again, the document goes into great detail about updated guidelines for inpatient and for diagnosis and testing. So in the outpatient setting, antibiotics should be started regardless of what bug is actually causing the illness, as long as the patient does not have any comorbidities or risk factors for antibiotic-resistant pathogens, such as MRSA. The recommendations are in order of quality of evidence. So first on the list, they recommend amoxicillin 1 gram 3 times a day. Second would be doxycycline 100 milligrams twice a day. And finally, another option is a macrolide antibiotic such as azithromycin 500 milligrams on the first day, then 250 milligrams daily, or clarithromycin 500 milligrams twice daily, or you can use clarithromycin extended release 1,000 milligrams daily. But make sure that's only in areas with macrolide resistance that's less than 25%. Now for outpatient adults with comorbidities such as chronic heart, lung, liver, or renal disease, diabetes, alcoholism, malignancy, or asplenia, they recommend combination therapy. So the first one would be amoxicillin and clavulanate 500 milligram, 125 milligram 3 times daily, or amoxicillin clavulanate 875, 125 twice daily, or 2,000 milligram, 125 milligram twice daily, or a cephalosporin. So that's going to be cefpodoxime 200 milligram twice daily, or cefuroxime 500 milligram twice daily. And on top of that, for the combination, they recommend a macrolide antibiotic. Again, it's going to be azithromycin 500 milligrams on the first day, and then 250 milligrams daily, or clarithromycin 500 milligrams twice daily, or the extended release version 1,000 milligrams once daily. Or they recommend monotherapy for those that have complications, such as a respiratory fluoroquinolone. And that's going to be levofloxacin 750 milligrams daily, or moxifloxacin 400 milligrams daily, or gemifloxacin 320 milligrams daily. And that's all I have for this week. I hope you enjoyed today's episode. I'll include all links and resources in the show notes below, so please go back and check those out too. Please connect with me on any of your social media platforms and give me feedback on what you heard today. I'd love to know what you thought about the episode. And as always, feel free to like, share, and subscribe wherever you listen to your podcasts. And thank you so much for tuning in today. I hope you enjoy the rest of your day. Music by Joseph McDade.